Ina manu, ina iwi, ina hoefa, tēnā koutou, tēnā koutou, tēnā koutou katoa. In the language of the Indigenous people of my country, Aotearoa, New Zealand, I'd like to acknowledge the traditional owners of this land, past and present, also the APNA for supporting my attendance, and also everyone who the Four Winds have brought here together, because most of us are travellers in some way or another. So my name is Lesley Batten, and I'm delighted to be presenting this paper on behalf of myself, and Mandy Bevan and Debbie Davies, two other amazing nurses who have been part of this project for a very long time. I was fascinated to hear about the project that Bianca's just explained for us, because that was a really good example of a really short project. Mine's an example of quite a slow, long project. Also, we already have the flu vaccine started this week in New Zealand, but we've already had our confirmed doses of flu. So we're a bit interested in what's happening here, and it was great to see those examples. So I'm going to talk to you today about a project that's been about integration, and I know that that's a word that many people use. Hopefully you'll get the idea about what we're meaning in terms of integration and what was specific for us. And I've called it co-designing bridges for gaps between services, and you'll see why in a minute. So first of all, our place, or my place, relates to the Mid-Central District Health Board region. This is a region that covers coast to coast across sort of the lower middle of the North Island of New Zealand. And we cover an area, we have a population of about 180,000 people in that area. Most of them are urban, but many are rural. Not quite as rural as you are when you talk about rural, but we've had a bit of problems with our census in New Zealand. We went completely electronic last year and it doesn't quite work. And so we're still waiting on a data, so we think it's about 180,000. We've got a really diverse population. We have high levels of Māori, we have high levels of over 65 in pockets, we have 2 refugee receiving areas, we have rural and urban spread, and currently we are geographically quite challenged. You can see here a key river in our environment. This is the Manawatu River, and this goes through the centre of our region. And in the background you can see some windmills that are on some of our hills. These are the Rohini and Tararua ranges. Right through the middle of those hills this river runs, and it's a major geographical barrier between 2 sides of our region, and we split all our services across. But what happened was a number of years ago we had some major slips and earthquake activity, as we have in New Zealand. And as a result, that road between, the key road between where we're living and the east of our environment has been blocked, and the government has decided they will not rebuild it. So we have 2 temporary sort of farming tracks, but we have all the major traffic going across. This causes a degree of mayhem for us. The other thing that's significant about our area geographically is we do hills really well in New Zealand. We have lots of hills. That causes chaos for our cell phone coverage. So although our maps from our cell phone providers show us all being beautifully coloured at ground level, and most of the nurses find it's black in many places. So this is the project that I'm going to talk about. It was Primary Healthcare Nursing Integration. It was a project that started in 2016 with a little resource, that was me, and a couple of other people involved. And it was based on the recognition that we had a large number of nurses in primary healthcare roles working in the community. But we also had the concept that we talk about quite widely in New Zealand, and we have been for at least 30 years, which is the number of Toyotas up the driveway. Most of nurses in New Zealand that are having a car that is provided by their work have a Toyota Corolla. And it was, when I was a public health nurse, it used to be that they were actually red. That was seen as the key colour for safety, but now they're all silver. So 30 years later, we're saying what's happening here. But we knew that there were lots of nurses in primary healthcare roles. They were employed with they had different employers, different titles, different skill sets, different links, but actually not a lot of integration. So we had lots of siloed services of nursing. And so the initial aim was to align and integrate nurses in primary healthcare nursing roles, and we decided to start with 2 groups. One was the district nurses who were employed by the District Health Board, the Public Health Service, and the other was a number of general practices that are of course private employees. And those private employees that we were looking at were working in our new integrated family healthcare centres, where we've had lots of little wee general practices that might have had 1 or 2 GPs all join up. So suddenly there might be 10 GPs and 4 nurse practitioners and 10 practice nurses working together, as well as other services. As soon as we started the project, and I come from a background of working in health and Māori health research, we demanded that we actually added equity really clearly into this project. As a result of that, we needed to make sure that our outcomes were at least as good as, if not better, for populations that were Māori, Pacifica, refugee populations, because we know that those are underserved and we need to improve the outcomes. We chose to use co-production techniques, and so as a result of that, we used co-design, we used many workshops. I did a lot of scoping. I'm a really nosy nurse, so I spent lots of time out with nurses and I experienced their day-to-day activity and their world and took a helicopter view about what was happening. I also undertook interviews with patients who were shared across a number of services, and so as a result of that, we developed patient journey maps. We had lots of workshops and lots of little meetings. I'm not into big meetings. We have really short, sharp meetings. Halfway through the project, when we did a big analysis of what was the data, we decided that integration actually wasn't the key driving force that we needed to get too tied up with. That actually it was about shared care, and it was the patients who are shared across services, and that's where the gaps exist. So we have amazing services with amazing nurses, but it's when you have patients that have to navigate across that's the challenge. So as a result, we flicked some work and started working in a different way. And today I'm just going to talk very briefly about 5 challenges that we've experienced that might be similar things that you have seen. So one of them was about language. At the beginning, we all talked about integration and then realised there's a few million definitions, and that actually when I talked to nurses, they automatically assumed that they would lose their jobs, they would lose their identities, they would lose their employers, they would lose their specialisations, they would lose educational opportunities, and it was all about loss. So it took quite a bit of time and patience to turn things around, and one of the key things was that, as I have a bit of a theoretical bent, I found a continuum model about integration that takes things from being a siloed services at one end of a continuum to being fully amalgamated, amorphous blobs at the other end. And the key argument that goes with that theory and approach to integration is that there's no right method, there's no right level of integration for every place and every service. So we allowed services to co-design how far they wanted to push the continuum, and that actually turned us around. So as a result, what we've ended up doing is streamlining processes, identifying and bridging gaps, increasing the visibility of primary healthcare nursing teams. That's been a key theme of this conference so far. Clarifying nursing roles, relationships, seamless transfers between patients. And so we've had quite a few outcomes that are quite different than are in the original plan. The next lesson relates to strategic thinking. I really like that idea of just sitting there and thinking, what if? For me, that's really exciting, but I really quickly learned that 1, nurses are too busy, and 2, actually it's really hard to do that when you're tied up with your everyday work. So as a result, we started saying, let's turn things around, and as a result, every one of our workshops, we started with a patient journey map. This was provided to all of the participants, and we spent the first half an hour discussing what's going on in that map and what works and what doesn't. And then what are we going to do about it? So we then co-designed the solutions. We had many common themes that were across our patient journeys. And I really, as a researcher, I just really enjoyed going and interviewing the patients. 1, they loved the nurses. We've heard that before. They thought that the care provided was amazing, but they assumed that every nurse knew everything about them already. And they were really flabbergasted when nurses kept asking them the same questions time and time again. And they'd say, but I've already told them that before, or the other nurse. They couldn't remember which nurses were involved because it doesn't matter to them. It matters to us, but it doesn't actually matter to patients. They want care. Self-management was a key part of the work that these patients were doing. However, they realised that you had to learn the system. And actually, I'm really worried when we have patients that spend so much time learning the system, because actually it means that we're not communicating well. They wonder why the system doesn't work well. They think that the health system is overly complex, and it takes considerable time, energy and resources to engage with it. So this was a key learning for us to think about how could we ground our work. The next one is that in relation to this project, we needed to allow change and allow time for change. And it's quite surprising to realise how we had to stretch things. So over time, we did have to realise that forecasting timelines for this type of project that is around culture change is actually an art rather than a science. And that if you're going to be involved with culture change and you have services that during a project need to continue providing care, that you have to slow down and go at their speed. So we can now see that we've had quite dramatic change in care approaches, but interestingly, the nurses now who were most involved really struggle to remember what it was like at the beginning. They're just so embedded in a new way of working. So there's a number of things to consider with timelines. Those relate to that idea about culture change is slow. True co-production takes you in different ways and in expanded ways that you may not be able to foresee. Different services have really different levels of flexibility and adaptability. And one of the key things we found was that the services that had really strong policy environments actually had quite a few barriers to change. So as a result, we did lots of rapid cycle quality improvement. I sort of banned PDSA cycles. And we used really fast pragmatic change when that was appropriate. The next one that we've heard already is relationships are everything. So if we've got relationships, that means that communication works effectively, but you have to have the relations first. And when we started this project, many of the practitioners had loose relationships. The district nurse knew the general practice nurse. However, what we found was without the formalised processes, that was a struggle. So some of the key processes that we've had development of individual and service level relationships and much clearer ways of communicating across services. And that means that we've been able to solve problems really quickly, and we've been able to have seamless, soft transfers of patient care rather than the hard, clunky, facts-based approaches. The last lesson is about IT, and I've been so delighted in a really sick way to hear that you have some of the similar challenges that we have. I thought it was just New Zealand that was wedded to fax machines. I was really surprised when I started this project to find that I was going to spend so much of my time and energy actually working about IT. We've got all sorts of issues, and that's because our nurses in the community have been so invisible to the bigger system for so long, they've been left off all sorts of projects. And one of the key aims and outcomes of this project has been that our community nursing services are now at the forefront of our brand new digital health strategy for the whole region. And that has taken a lot of work, and I've had to advocate in ways that I never could. People quite rudely now say I have 2 PhDs and one of them is in IT. And that makes me feel quite sick because it's something I don't want to know anything about ever again. So, and just in summary, we've made some more progress. There's some more of the bridge built, and I was just delighted when they had to build this bridge just for me, just down the road. We're involving other nurses and other roles. We're pulling them into our groups. We're sharing it across geographical areas. We continue to focus on equity. We're ensuring that we have workforce planning. We also have quite some challenges in knowing who's who in the zoo. We're looking at sustainability of nursing services, and co-design works really, really well. So, nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Thank you.